from I've run into this with a nurse wife as a pharmacist
And EMT.
and EMT. Good point. Yep, I almost missed that. Thank you for that. In her education, they were taught drugs based on brand name. And almost
I was
exclusively
literally
brand
just
name.
typing the note to myself to get back to talk about
Yeah.
that. But go, yeah, brand name versus trade name.
And pharmacy,
Generic name.
yeah, in pharmacy, it's really, really focused on generic. You have to learn
Same
both.
with med ed, us too. We learned generic names.
Yeah.
That's what we learned, and it wasn't until we went onto the wards that we got to pick up a little bit of the trade names. But yeah, we learned the generic names, which is not what we use, and we have made a big change within the last year to specifically change our education. I've tried really hard to say midazolam instead of Versed, or ondansetron instead of Zofran.
Right. Yeah.
But Zofran's easier to say than ondansetron, which is why we do it.
Right.
Yeah.
Yeah. And there are still some more seasoned nurses than I am a pharmacist who will throw out trade names that they learned back in nursing school that have not existed. It may not have existed in those days, but that's the name. And I'm sitting there looking up, like, what in the world is that? Like, why didn't you just say hydralazine? I didn't. But that's how they know it. Yeah. And as we work towards a more interdisciplinary approach, recognizing that sometimes we have translation issues.
Yeah. Was it last year, year before last? That was the big push from the protocol side of things. And we went back to things that we take for granted, like this is actually, you're going to be so proud of me. I can't think of the generic name, or I can't think of the trade name for Ketorolac.
So, Toradol.
Toradol, yeah.
Yeah.
And correct me if I'm wrong, not even produced in the U.S. right now. It was only a Canadian or something like. There was something with,
There's a few,
or it was PO only, or something like that. I remember, but that was a big thing. It's just like, still to this day, I say you're proud of me. I already washed it out of my brain, but we went through and stripped all of the trade names out of the protocol just to generic. And the other part of that is the simple operation of nothing in that box. Very few things have trade name on it. The only thing that comes to mind is Solumedrol. Yeah. I have never seen a methylprednisolone generic. I'm sure it exists. I just have never seen one. Yeah. It's always been in the Actidose vial, which has the trade name on it. But I can't think of anything else off the top of my head. I'm sure you've got something in there, but.
They just couldn't get it on the label. You'd be spinning the whole thing. You'd be sitting there trying to read the name of the prednisone all the way around. You'd be like, yep, that's it.
Yeah. So,
but
couldn't
I
shrink
mean,
the
even
font
with
enough.
Tylenol, we have acetaminophen, and then you have, I have to look it up. The trade name in UK is, I just lost it now.
The paracetamol?
Yeah.
That's, I think that's the generic
name. Instead of acetaminophen, it's paracetamol.
Yep. And then there's a Panadol, which I think might be a drug name. So even that, it's a same drug,
it's
just
exact same thing. Yeah.
Depending upon country of origin, it's going to be called something else.
Yeah.
I was working as an intern at the Giant Eagle in Toledo, which has since closed. But we had a guy coming in. I can't remember if he was a exchange student or was just there visiting, but ran out of all of his meds, and he's coming in with, and it was half the meds were a different, names we'd never heard of, and it was basic drugs, the fast mover section. But and as you have patients potentially from other areas, they may tell you I'm allergic to this, and it's a whole different thing than what we're used to.
That just creates such a different issue if we're talking about if you're rendering care to someone who doesn't natively speak English and who is not natively from the United States, and they maybe just moved here with family and they're not used to what our drug names are, and they're trying to tell you what their allergies are or what drugs they're on, and they're using different names.
Or you're using like a translator app to try to even communicate with them, just because you have the language barrier to begin with, let alone now let's add a medication language barrier, for lack of a better word, there too.
Get a hold of a pharmacist pretty quick, because we have the databases to make some of those. So we can get that info relatively quickly. But yeah, that is the beauty of an interdisciplinary approach. Is you get in this. We talked about phone a friend, right? There's a lot of friends out there.
Let's talk about physical security of these things. That always seems to come up. Not necessarily this particular box, but just medications in the field in general, right? So what are some of the rules and the concepts? And of course, for the viewing audience, we're framing this up in this is state of Ohio, and your rules may vary, be more lax or stringent, but I think we're generally middle of the road on these things. So I would expect them to be pretty damn similar.
Yeah. And so the big thing as you're trying to think about the security of the drugs is who has access, and effectively, if you can give it, you can access it. If it's within your scope to give the medication, you can access the medication. If it's not, you should not. So, this is our ALS box. For an EMT, they should not be accessing this box. Now, does that mean there has to be a physical lock in place to prevent that? Not necessarily. And we have these green tags. It doesn't take a paramedic certificate to pull that off. That it's pretty easy. Pop that right off there. But the big thing with the Ohio State Board is it's tamper evident. So if somebody goes into there, you're not going to be able to really glue that back together without it being obvious. The drugs need to be protected from the public, and so we want that behind a lock. Now this counts as a lock here, right? But we want the box to be safe, so you can't just to run off with it. So locked in the ambulance, locked in the station, locked in the pharmacy. And if you can't lock it, thinking like event medicine, your golf cart. When my wife was on here, talking about the gators, the golf carts, what have you. There may not be an opportunity to lock this box on those vehicles, but if you have that constant, somebody constantly there seeing it,
control, yeah,
that's acceptable as well.
As a security line.
Yep.
How does that change for controlled substances? So that's
the big one. Yeah. So controlled substances, we're going to add that additional lock. So there's another green tag on the NARC box, and one of the things that we do is with these boxes, if a controlled substance is used out of that box, it immediately gets red tagged and it's not to be used again. It prevents that. We only use one fentanyl, but we're going to keep pulling duonebs out of here. No. Once we hit that box, we're going to red tag the NARC box, red tag the orange box, and we're done with it.
And our system is, pretty straightforward. It's red, yellow, green tag. It means exactly what you think they should mean, right? It's good to go. It's sealed from the pharmacy. It's yellow. Hey, somebody else has been in this. And then red is it's out of service either for controlled substance or
you've used up
lack of
all the medications.
Right. Yeah. I tapped out all of our dextrose in this, and I can't service another patient with it. Yep.
Right.
So, what drugs constitute controlled substances? So, that is, I'll use haloperidol for example. Everybody's like, it's a controlled substance, and it's not.
Nope.
But you want to talk a little bit about the drug schedules and what drugs fall in there, and essentially what that pecking order is and why it's important.
Yeah. So controlled substances, to simplify it, it's essentially comes down to drugs of abuse. So you have your Schedule 1s, and this is set at the federal level. So your Schedule 1s are the medications that are not used medicinally. Therapeutically, your heroines, your LSDs, the PCP. Marijuana is still a Schedule 1 federal substance. So we're not. Let's take marijuana out of this. It gets real confusing real fast.
I don't.
It's a little muddy.
Yeah.
You think 911 calls are bad now?
Yeah. Right.
those medications, we're not going to be using therapeutically. You get into Schedule 2s, a high abuse potential. We're talking medications like morphine, fentanyl, your stimulants, your Adderalls, Ritalins of the world. Those medications are going to be Schedule 2. They are, tighter restrictions for prescribing, for dispensing. With any of these scheduled substances, we want to make sure a good chain of custody is in place and that kind of. We go then down Schedule 3, 4, 5. This is where we're going to catch your benzodiazepines, down into a Schedule 5. If you've taken, cough syrup with codeine, used to be over the counter, even though it's a Schedule 5. I think technically it still can in some places. So, still abuse potential, still potentially addictive, but less so than some of those Schedule 2s. Yeah. But those are the ones, nearly everything in this box fills or meets the definition of dangerous drug legally.
Drug, right.
The controlled substances require that little bit extra. So we're going to have tighter control over any of these controlled substances, making sure those locks are in place, making sure the chain of custody is in place. It is a pretty hefty fine from the DEA if you don't have a chain of custody, and you lose that, it gets compromised at any point.
You skipped over our Schedule 3, our favorite Schedule 3, which is
Ketamine. Oh yes.
Yeah. EMS's solve all.
Yes.
Well, notable drugs too, like anabolic steroids are Category 3, Neurontin and gabapentin, Lyrica, pregabalin are also scheduled drugs too. They get tracked. And also realize Schedule 1 drugs are tracked in the state of Ohio, and all these drugs of abuse, if you get them from a pharmacy, are tracked system statewide. So we use that information in the emergency department. Pharmacy definitely uses it because they report to it that if they're dispensing these medications to individuals, there is a state system that tracks all of these dispensing of medications, and that's all to help stop diversion and abuse.
Doctor shopping and all of the
And there's some then drugs that fit into, they aren't technically controlled substances, but we treat them like controlled substances. Propofol and gabapentin are two examples. We still are going to report those. From the hospital side, Joint Commission, DNV, Medicare, they will require that we do the same type of security, or I don't know if it's technically a requirement, but
best practice.
Best practice. Thank you. Best practice. Treat those like a controlled substance because they do have that abuse potential, even though they haven't hit that federal level yet. But we want to make sure that we're monitoring those and reporting those appropriately. So that just adds another little layer of complexity.
Yeah. Well, there's an EMS analog to that as well, and there's another local system that puts their Haldol, and that's kind of why I led off with that, because I've gotten many questions from providers about that. It's like, why isn't our Haldol locked up in the box? They treat it. They go ahead and they just, in their mind, it's a best practice, and they don't want that inadvertently given to somebody without going through that extra layer of security. It's one additional stopgap just to prevent inadvertent administration, and they put it in with their controls, which is absolutely fine decision on their part, and support that. But then we get why don't we do it here? It's okay to be out in general population. It doesn't have to be, right?
Yeah.
Nobody wants it.
Right.
Nobody's gonna come divert it and steal it, and what am I gonna do with it?
Yeah. But I think I like to mention though that we separate off these scheduled drugs into a separate box because that's best practice. But those are dangerous drugs. But probably one of the more dangerous drugs in this is going to be your labetalol or metoprolol. I can do a lot more damage with those medications that are on the top shelf than it probably can with most of the other drugs. So understand that even though it's a drug that's maybe common that we use, that if I give too much of that medication, I can cause severe harm to a patient, even though it's not a controlled substance.
How many stories this year started with the patient got a lull and ensuing cardiac arrest, right? Because they used the wrong lull in the wrong situation, right? Yeah. we get a lot of flack on the protocol side of things because we carry both agents, right? Labetalol, metoprolol, to your point, and they're both red boxed, and meaning that we have to call for online medical direction per case use. And it's like, well, you guys don't trust us to use this, da 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 da. It's like, no, this is extremely high potential for error, and the therapeutic nuances between the two are such that it's easy to miss, especially if you're hustling down the road or something, and you're given a hypertensive tachycardic patient the metoprolol when you actually wanted to bring the blood pressure down with the labetalol. You can cause problems, right? Yeah. And we catch a lot of it. It's like, that is for everybody's safety. That's not because we don't trust you. It's because that's hard for
even with
all clinicians.
Those antiarrhythmics, there's sometimes that I have a question and I will call cardiology or even pharmacy. Say, hey, they're on this. I don't know what to do. Do I do this or this? What's going to be safer for them? And then I'll get that extra guidance. I'll call for help because it's a complicated case that I just don't know. That I want some other input on, like, let's talk about what the nuances are of the therapeutic effects of this medication that I want to give or should be giving.
Yeah, and it's not like these patients that come in aren't on a plethora of other medications as well, with like polypharmacy,
Yeah, how many years have you gone to school to understand all those interactions and still have to look stuff up? I'm sure.
Constantly, yeah.
I can't be that good. I can't.
That program makes it so easy.
No, right.
Yeah.
Well, that's why we have these tools, these electronic tools that we're using, whether that's our EMR or other tools we have to warn us, hey, dum-dum, the patient's on this med, are you sure you want to give that medication? Right. Or, hey, warning that those two medications can't go in the same IV line because they're going to drop out a solution.
Yeah.
Although I intrinsically know that, and I'm sitting here wondering, why do none of our EPCRs have that same level of... I cannot think of anything we use in our system that gives me that auto, this conflicts with this if you put in their medication history, right? And I'm going to give this.
Or, hey, the patient's on cardizem, you want to give beta blocker. Are you sure you want to give these two different separate antiarrhythmics?
Really? Yeah.
We find this with a lot of things, right? You potentially solve one problem, you create another, right?
Yeah.
So how often do we run into alert fatigue?
Oh, God.
Because there are, you have to figure out at what point do you want alerted. Yeah. Because there are alerts that, hey, this one time in an animal study, their fur got a little bit shorter. Are you sure you want to give this medication? It's like, well, I think we're okay. And then you run the risk of missing that big, category X, do not put these two meds together. But you also run into these scenarios where, but this is that really weird caveat case where it's very okay to do that. And there's a lot of clinical judgment that can go into this of at what point do we want alerted, and then what do we do with that alert? And we're digging in sometimes into the studies themselves to figure out what actually happened. How was this set up? Do we care about this thing?
Does it apply in this situation?
Yep.
Yeah.
And all it takes is, but the patient took it last week and everything was fine. You're like, oh, okay.
Yeah.
Cool.
That's the best option.
That was
Seems safe.
Yeah.
Seems safe. The trial was already done for me. Yep. I like it.
Yep.
Yeah.
Well, to that point, there's times in the emergency department where we run those trials. A great example is penicillins. Penicillins probably reported as one of the number one allergies.
Yeah.
I got a rash when I was a kid.
Right here. I don't know, right?
And there's lots of times where we will give it, and if they don't get a rash after I give that penicillin, I will take it off their list. But what's the best place to check that allergy? It's in the emergency department, because if you do anaphylaxis from it, I can intervene and fix that. Not the best way to do it. It's a judgment call, right, that we're going to take or look back and say, they've had cephalosporins before. We're going to go cephalosporins instead of penicillins, but I digress.
Too, and I think understanding the patient's interpretation of I have an allergy to that medication versus I have a
intolerance
reaction I don't like, or a discomfort maybe,
or my mom has a reaction, therefore I've never taken it because I might have a reaction. That we see that all the time.
The follow up.
Tell me what happens. Yep, exactly. Yep. Another piece in here is, what if something gets lost, right? What if in the course of we'll get
Been down that road.
We've all had this. Right? We'll give Ray's example of this box got shaken up, tray gets flung open to get to some arrest medications on the bottom tray. Something topples out. It's rolling down the road. Nobody knows it. After the fact, either you guys catch it. In our case, would be electronically with kit check, or we get, we're like, hey, I thought I had XYZ set out or whatever. Now we can't find it. It's in the truck somewhere. What's the process? What needs to be done in situations like that, other than trying hard to look for it?
Well, and I think the level of effort that we're going to put into trying to find it is going to matter a little bit on what kind of medication we're talking about, right? Do we lose a Tylenol?
Do we lose an albuterol? Yeah.
Right. Do we lose a fentanyl? And those are going to be two very different levels of we're searching. And I know from the pharmacy side, there's some where you drop a med on the floor and you go, I'm not picking that up. You kind of kick it underneath the machine. And then there's other times where you're going to find that one because fentanyl rolled back there and you're pulling out like hundreds of pounds of equipment to get to that one little vial. But yeah, so you lose a med. So you retrace your steps, try to find it. If it's a controlled substance, start ripping apart the ambulance, start really, really trying to find it. But pretty quick, you're going to want to let your pharmacy know, wherever you're getting your medications, whoever's in charge of your medications. Especially if it's a controlled substance, at some point here, we're going to have to report that as a loss, usually to your board of pharmacy, as well as if it's a controlled substance to the DEA. And so, for the UH squads listening, watching here, you're practicing under the hospital DEA when it comes to the controlled substances. Your department will have a board of pharmacy license. So those reports really should go together, and that becomes a collaborative effort. So if we've done everything we could to find it, it's lost. If at any point we think it's stolen, we gotta ramp that up. You're going to want to bring, if it's stolen or you really don't know what happened to it, there's a chance it was stolen. Good idea to start getting local law enforcement involved too, get a police report, and then start getting in communication with the board of pharmacy as soon as possible. DEA is more of a paper report that you send. If it's 1, 2, 3 things, it's the first time in a long time, they're probably just going to file that away. Obviously, they're going to be looking for patterns, right? Absolutely. So and then that might prompt a visit. Board of pharmacy, depending on the situation, they may come out and take a look. How are you storing these things? How did this thing happen? They know stuff happens. Did we do what we could to prevent it? So the really weird one-off case.
Oh yeah, we've been down that road a couple times.
Yep.
Derek and I have. And the board of pharmacy is very easy to deal with if you tell the truth.
Yeah.
And you're very upfront. So that's one of the things I think we want to convey to our squads, and early notification to everyone that Derek just mentioned. If a lot of times when I was the coordinator at Portage, the squad would usually call me first. Hey, we're missing solumedrol. I'm just going to make a med up, whatever. Hey, I'm missing solumedrol or methylprednisolone. And we can't find it. We've dug through the box. We've dug through the ambulance. Da-da-da-da. If it was close, a lot of times I would go there. We go through the ambulance together. We would take everything out of the drug box. Sometimes it gets shaken up. It's in the bottom. Hey, we found it. You know what I mean? Another set of eyes is always a good thing. Plus, there's panic that sets in to an extent, too. Like, oh, my God, I lost this. This is bad, right? That's just a normal reaction. But I think early notification or EMS coordinator, early communication with the pharmacist, to see what level do you go to next. And then we had some cases where we had early notification to the board of pharmacy. We had an ambulance that went on a call and had lost an entire BLS drug box, essentially. So we're like, okay, retrace your steps, involve local law enforcement, go back to the residence, see if they'll allow you to gain entry, those types of things. No, we don't have it. No, we don't have it. Pharmacy was notified. The state board was notified. Written statements were done. Police report was all done. And that was just BLS drugs, right? And we lost no controlled substances. But all the proper channels were followed. to the point when everything's submitted to the Board of Pharmacy at that point in time. Said drug box shows back up at the fire station, delivered and handed back to the ambulance with nothing missing out of it. So then we call the Board of Pharmacy back literally the same day and was like,
stand down.
Hey, this is it. Da, 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 da. Okay, thanks. Like, they're really good with that, you know? So I think good documentation on that is key there. Broken vials, we've always documented, you know, epi ampules when we had those seemed to be a big thing. You know, and we would fill the sheet out. You know, how many epi ampules did you use? I might have given a Zofran and something else, but since I dropped the drug box and I broke 3 ampules, I put 3 epi and then, you know, put a note on there, right? If you did that, clean the glass shards out. That was always a big thing we always talked about. Or I remember when hydromorphone used to be in the Carpijet, right? I literally watched a paramedic take off the end of the little green tip to put it in the Carpijet, take off the end, put a needle in it, shove it in there, and just inject air, and you just watch the rubber stopper come out of the end of the tube, and all the hydromorphone just went sailing, right?
Aerosolized.
Yes, aerosolized.
For everybody to enjoy.
Yeah, so then now you need to explain that in your EPCR report, and then you also need to leave pharmacy report that says, I essentially just wasted all of this drug and did not mean to, right? So those types of measures, I think communication's key. We've had those a couple times. It is a big deal if you lose a drug box, though. We did have a squad underplay that when they lost a BLS drug box. Dan, I think, definitely corrected that. But it is a serious thing. You need to try to locate it as soon as possible with all the steps and communication that we spoke about. Because you are responsible under your terminal distributor's license when this said drug box is dispensed in theory to you as an organization. Now, if this is ours at our organization, then it is our responsibility for oversight, making sure it's locked up. And the Board of Pharmacy is doing a lot more site visits. So I think if you lost something, even if you follow all the proper channels, I would not be surprised if a Board of Pharmacy representative showed up at your at your shop to take a look around and see how are you storing the drugs, how are they locked up. You know, let me see your records on that. When do you sign for your drugs? Right? Yeah, they're just they're doing an assessment to see, hey, is there something we could correct here? You know, I mean, people make mistakes. Don't get me wrong. Sure. Things get dropped and broken, but you know, don't be surprised if they show up. They've done some more site visits, and we're very open with the Board of Pharmacy in Ohio. We communicate with them a lot. Hey, this is what we want to do. Is that okay? Or you know, this is what we're dealing with. Can you give us another solution maybe? How do we come to an adjoining solution? That's all about communication.
We had one within the last couple of years, and I know because I keep having to report on it because a lot of the paperwork that I fill on the hospital pharmacy side is in the last 3 years, have you had a theft or loss? And I keep having to say, sure have. You know, and
you have to reset.
Here's all the stuff. Yep. I keep it in a folder with a paper clip on it. It all stays right there. But it was a controlled substance box that probably got used and left outside of the box. We never got it back. Don't know exactly what happened. My guess is rolled up in the sheets at the end of it, and who knows where it is now. But you know, I gave 24 hours. Like, you got 24 hours to look at it before you have to report it, because this is controlled substances we're missing.
Big deal. Yep.
There were some other factors that made the water a little murky. Was this a theft? Was this a loss? Couldn't really come down on either side. And yeah, just bringing those people in, and the boards all talk to each other. So bringing them in at the same time. So EMS board, nursing board, medical board, pharmacy board, whoever needs to be included, that's same time, you know, because they're all going to find out real quick. But yeah, and you know, they want to know, what have you done? What have you done?
Yep, there it is. Yep.
And here's some things to consider if you haven't yet. Correct. You know, why did this lock change and you didn't know about it until some other time? Like, we don't have a log. Hey, you should have a log. Yeah. And next time we come, we're going to make sure you have that log,
we're
right?
We're going to expect said log, right?
Yeah. But yeah, and communication, don't hide it. If you hide it, we're in a much different situation then.
Yeah.
And I think that's something we wanted to talk about with this episode is we want you to communicate errors, communicate losses, communicate mistakes. the worst thing you can do is hide or lie about it.
Yep.
And that is when you're going to have the consequence of loss of your license to practice either EMT, advanced, medic, physician, even pharmacist, right? So that's when there's always consequences to it, but that's when the big consequence of loss of your ability to provide for your family, right?
Yeah.
Your ability to do your job comes into practice. This is when you lie, you cheat, you steal. If you make a mistake, again, we know that's going to happen. Be honest about it. Or if you lose something, we know it happens, less than ideal. We'll work through it together. But if you lie about it or you try to cover it up, you've now lost trust.
Correct.
From your agency, your medical director,
Sure.
your leadership, the pharmacy. I don't want you practicing under my license. He doesn't want you taking drugs under his license. Your leadership doesn't want you giving drugs under his license. That's when the big consequences come in, and we do have to make those reports to the pharmacy board, the EMS board, and all those things.
And that's where record keeping is important, too, to piggyback onto that. And we didn't talk about this yet. I know it's specific to Ohio, so if you're in a different state, I don't know how it works, but that's something we worked with the Board of Pharmacy on. If you're a full-time staffed, part-time staffed, either way, if you have staff in your building, EMS district, whatever, private ambulance, if there is somebody in your building every day as an employee, then you should be recording your drugs every day. Best practice is to have a drug log that this is box 307, it expires here, it's got a green lock, here's the tag, right? That is best practice. If you're a volunteer organization where there's not somebody there every day, we talked about once a week, training usually occurs once a week.
Yep.
Training day, then that needs to be the day that when you first come in, then you need to sign for all the drugs, and that helps catch some of those things. God forbid there was any type of loss, diversion. This is open. What happened? Like that starts to give you that path back. So does kit check. When was it issued? When was it taken out? Which department was it issued to? A lot of that stuff starts to help if someone is not A, didn't know, or B, is not forthcoming with information. So some of the stuff that we use is also good oversight for the board and for us.
Yep. And a lot of places that store these drugs, whether it's they're manned or unmanned, have video cameras on the door to get to the drug boxes inside those where the drug boxes are stored, or even on the outside of the property to see who comes in.
Or in the bay on the apparatus, right?
Yeah.
Point of camera to ambulance.
Yep.
And talking about that, we talked about security of who has keys to that cabinet matters. Again, if they can't give it, they shouldn't have keys to it. So making sure that it's the right people that have the key, not on a master key that maybe somebody who's
the entire organization has.
Right. So those are important things. Not to go backwards, but important point from back then.
Well, to that point, I was in a fire station recently where I was doing a project and I needed access to their storeroom. I had to ask one of the firefighter medics, I'm their medical director, hey, I need to get into your storeroom. And he needed to let me in because I don't have direct access to it.
Sure.
I'm their medical director. I can have access to all that stuff.
Right.
Nope, they're still going to let me in. Just that's the type of control you should have.
Yeah. And I want to expand a little bit on your commentary about risk of losing your license, like at a state level, right? Or your certificate at a state level. Your local medical director ultimately, let's say something was reviewed by the board, and they took no action on it, or there was no finding.
Correct.
Right?
And sometimes, honestly, what the board will do is they won't do a finding, and they'll just refer it back to the local medical director to make their determination of what should happen.
Correct. So, that needs to be stated is you can't take away their certificate or license.
Yep.
That is all resides with the state. However, you do not have to allow somebody to function under your license, right? Which is the EMS model.
Yep. So the model in the state of Ohio,
the states, right? We have some international viewership. It might be.
You guys are not licensed to practice independently. You are licensed to practice underneath a supervising physician. For my med control, it's my license, so they function under my supervision. They're doing things independently, but I am still supervising them, and I am responsible for that. So when a mistake or something comes up like this, we're going to review it. And oftentimes what we'll do for university hospitals, if it's a big mistake or a big misstep, we're going to involve a large group, a board of people to do an investigation, get statements, and then collectively as a group make a determination of what that's going to happen. And for better or for worse too, is if we do make a decision as a group, as university hospitals, it's going to apply to my medical license as well as Dr. Garlisi's license.
All of our providers,
Because collectively we don't like what we saw,
Right.
so our intervention is you're not going to be able to practice underneath the university hospital's umbrella. And unfortunately, that's sometimes what we have to do. And that's could still be years until the board actually makes a determination of what's going to happen with that certificate.
Correct. It's
Yes.
it's much like Supreme Court law,
Correct.
right? It now becomes our position.
Yeah.
Yes.
And it's not something we take lightly.
It is not.
No, not at all.
We try to give everyone due process, but there comes times when you have to take those actions to protect myself individually as a physician, protect that agency that we're supervising for,
And the patients.
and the patients. Yes, the most important thing of why we're there. Like,
Absolutely.
I don't want a bad actor out there causing any harm to any of the
Absolutely.
patients.